to me, so
I know. Just
I
get
apologize.
Yeah, get this thing off. Close this out and then put your, there you go.
There we go. And let me pull up the presentation now. Okay, and why is this not coming up?
I don't know. It was working a minute ago before you.
I know. That's what I told you. It's just been fun times with this. There we go. Do you see it?
Yep.
Everybody, thank you so much for being patient. We just moved to this platform, so I'm still navigating. So Dr. Wynn, I will now hand it over to you, and we will start.
Thank you very much for that introduction, and thank you for inviting me to speak. Today we're going to talk about bariatric surgery, which is a subject that I'm very passionate about. And our goals for today are to understand the indications of bariatric surgery, understand the different types of bariatric surgery that's out there, as well as recognize when a bariatric surgery patient has a complication and needs attention. Next slide. So just a little history about bariatric surgery. So number one is bariatric surgery, or the first weight loss surgery, actually occurred back in the 10th century in Spain on the King of Leon. This gentleman was so overweight that he had a sword and eventually lost his throne. So he was actually treated by a physician who sutured his lips shut so he could only take in liquids. And then this physician gave him kind of like a concoction of different herbs and opium to drink until he basically lost half of his weight. Once he did that, he was able to regain his throne. And that was actually the first known bariatric surgery or weight loss surgery. In 1954, the first metabolic surgery was undertaken by Dr. Kremen. He converted basically the normal anatomy to what we call a jejunal-ileal bypass, where he bypassed almost all of the intestine, almost to the colon. And the reason he did this was to actually correct severe familial hyperlipidemia. And what he found was the hyperlipidemia definitely got corrected. All these patients actually had resolution of their issues. However, they started having problems such as liver failure, diarrhea, dehydration. And so that actually was not something that lasted. It kind of fell out of favor. In 1967, that was the year I was born, the gastric bypass was invented by Dr. Mason. And he did this after he noticed that when he was doing subtotal gastrectomies on people for ulcers or for gastric cancer, people would lose a considerable amount of weight and they had trouble keeping the weight on. And so when that happened, he realized, hey, I found a new way to help people lose weight and keep their weight off. And that's when gastric bypass actually started being used for weight loss surgery. Shortly after that, an Italian surgeon named Dr. Scopanero basically discovered, hey, I could do a better diversion than that. I could do a better bypass. And he came up with the biliopancreatic diversion, where he divided the stomach and bypassed almost half of the intestine, and patients lost a tremendous amount of weight. But there was some issues with patients becoming malnourished, so they had to focus on really supplementing with protein and vitamins. I'll be discussing the anatomy of that in a little bit. In the 1980s, the gastric band came about by Dr. Kuzmak, and it really didn't get FDA approved in the United States till early 2000. And there was a big giant boom of gastric banding that lasted about a good 7-8 years. And then the gastric sleeve came around and kind of replaced the gastric band. In 1988, Dr. Hess describes using a gastric sleeve as part of his biliopancreatic diversion. And he would preserve the pylorus. And in doing that, he had less problems with malnutrition and dumping. And he also discovered, as time went on, that this was an ideal surgery for people who were very, very severely overweight, BMI 50 or 60 or greater. And what he did at that time was he started kind of doing the gastric sleeve first on these patients that were super high risk, and then bringing them back a year later and doing the duodenal switch part so that it would be much safer. And the patients would not be on the operating room table for a prolonged period of time. And when he did that, probably half of his patients were saying, hey, you know what, I lost 40–50% of my excess weight. I feel great, I could move. And so many of them decided not to go and have the duodenal switch. And that's when, probably around 2004, when the gastric sleeve started becoming its own surgery. And it actually became very popular because it was a nice, simple surgery that didn't require a lot of bypassing of the intestine and not a lot of malabsorption. In 1991, the NIH had a consensus conference. And this was really what made bariatric surgery boom. And what they did is they looked at people that were trying to lose weight. And what they found was, with best medical weight loss, 95% of people would fail medical weight loss. And at that time, only gastric bypass surgery, as well as the vertical banded gastroplasty, were the two surgeries that were being performed at that time. And what they found is these surgeries allowed people to lose over 50% of their excess weight, and they were able to maintain that weight loss long term. And because of that, that's when the NIH basically looked at insurance companies and said, hey, it's time for you guys to start covering these procedures, because patients have tried to lose weight and 95% of them will fail even with the best course of action medically. So they should be offered weight loss surgery as a solution. Add to that, in 1994, Dr. Whitgrove from California discovered a great way to do bariatric surgery. He did it laparoscopic, and then he started teaching it to all these other surgeons. And that's when laparoscopic surgery really, bariatric surgery started booming. And that's when more people started getting interested in weight loss surgery, because rather than having a 4 to 5 day hospital stay with a very large incision, patients were having 4 or 5 tiny incisions. They were in the hospital a day or two. The complication rate went from 30% down to 1 to 2% because they didn't have giant incisions, skin infections, high rate of hernias, high rate of bleeding. It really popularized weight loss surgery and made it acceptable to the general public. Next slide. So why do we care about this? Well, the main reason why we care is, number one, for health, but number two is, look at the medical cost to the United States for treating obesity-related disease. It was $147 billion back in 2008, and unfortunately, they haven't really refreshed this number, but I imagine it's twice as much now. Just to give you an idea, just to treat cancer, it's about $157 billion back in 2008. So it's very similar as far as the cost that it's taxing our healthcare system. The indirect costs are anywhere from $3 to $6 billion, and that's due to things like absenteeism, premature disability, declines in productivity, as well as earlier mortality. And then when you look at it, obesity is the second preventable, most common preventable disease, second only to smoking. And as far as deaths per year, it's equivalent to smoking, 1 in 5 deaths per year. And nowadays, actually, every state in the United States has more than 20% of their adults being overweight or obese. So that's pretty significant when you think about it. Next slide. This slide didn't show up very well, but basically, I'll just give a summary. These are all the different problems that are associated with obesity. Pseudotumor cerebri, that gets better about 96% of the time as people lose weight. Migraine headaches, gets better about 50% of the time as people lose weight. Hyperlipidemia gets better about 60% of the time as people lose weight. Fatty liver gets better 90% of the time as people lose weight. Type 2 diabetes gets better 80% of the time as people lose weight. PCOS gets better 100% of the time as people lose weight. Gout gets better 72% of the time as we lose weight. Venous stasis changes about 90% of the time as people lose weight. Depression, I tell you what, if you get rid of all these other medical issues, depression would get better too. And depression gets better about 50% of the time as you lose weight. Sleep apnea gets better 75% of the time as they lose weight. Heart disease gets better, actually risk reductions 80% as people lose weight. Hypertension gets better 50% of the time as people lose weight. Reflux gets better 75% of the time as people lose weight. Stress incontinence gets better 40% of the time as people lose weight. And joint pain gets better 40% of the time as people lose weight. So the health benefits of losing weight are pretty tremendous. Next slide. So the surgeries that I'm going to talk about are the surgeries that are still being done today, which is can be broken down into restrictive surgeries, which are surgeries that restrict how much someone can eat by making the stomach smaller. So that's a gastric band and gastric sleeve, as well as the malabsorptive surgeries, which has a restrictive component, but also part of the intestine is bypass. So there's malabsorption that's associated with this, which helps improve the weight loss effect. And then we'll briefly talk about revisions. Next slide. So first, who's a candidate for weight loss surgery? The people that are candidates for weight loss surgery are people who have a body mass index 35 to 40 with medical problems like diabetes, high blood pressure, sleep apnea, or a body mass index greater than 40 with no comorbidities. We do screen people for psychological issues. They can't have eating disorders, uncontrolled depression, or substance abuse. And they must have tried other weight loss attempts and then have failed. And for us, age has to be greater than 18. Next slide. So first, we're going to talk about the gastric band. The gastric band basically entails putting a silicone band around the upper part of the stomach. It's almost up at the GE junction. Inside that band is a balloon that gets inflated when you inject saline into the port. And that port is buried underneath the skin, underneath the fat in the abdominal wall. And that allows us to adjust it without taking patients back to surgery. This is done laparoscopically. It's usually a 20 to 30 minute procedure. And the first adjustments for the band is basically done about 4 weeks after surgery. And we just lay them on an exam table, feel for the port, inject saline in there to make that band tighter. We could loosen it by taking some saline out. And usually we bring them back every 2 weeks till the band is adjusted just right. Next slide. So the estimated weight loss with the gastric band is about 40 to 50% of their excess weight in a 2 to 3 year period. So if you're about 100 pounds overweight, they would lose anywhere from 40 to 50 pounds over that 2 to 3 year period, with the majority of that being in that first year. It does have the lowest complication rate. It's also one of the simplest surgeries that we do. It is reversible. It's one of the only surgeries that we do that's reversible. But the weight loss is slow, and it does require a lot of maintenance, meaning people have to keep coming in to get their band adjusted. There's a risk of the band eroding through the stomach, which makes it a disadvantage because the most common cause of band erosion is actually frequent NSAID use. So people that need to take NSAIDs for any reason, this is not the ideal surgery. The band can slip too over time if people do a lot of overeating and throwing up, and overeating meaning 1 or 2 bites, and it sets them into a vomiting regimen, then essentially that band can slip down to the middle part of the stomach, which is a lot thicker, and cause strangulation of the stomach. That is usually a surgical emergency where we have to take them back to surgery, reposition that band, or just cut it out temporarily until their stomach heals up. It is a foreign implant, and so adhesions can form to it, although it's very rare. And then, like I said, it does need frequent adjusting. Next slide. The band has largely been replaced by the gastric sleeve. The gastric sleeve essentially takes a stomach that's, normally the size of like a Nerf football, I usually say, and then we basically pass a bougie that's about the size of my finger, a 40 French bougie, and then divide alongside of that, so the greater curvature of the stomach, or 2/3 of the stomach, is completely removed. And that just gives a narrow sleeve of stomach, which causes restriction in how much someone can eat. It's good portion control, essentially. Next slide. So the estimated weight loss with the gastric sleeve is anywhere from 50 to 65% of their excess weight. Another way the gastric sleeve works is people's hunger decreases due to decreased secretion of ghrelin, which is actually secreted by the greater part of the greater curvature of the stomach. The surgery actually can be done in less than an hour, so it has low operating time, which makes it ideal for people that are high comorbidities or super obese, but it's not reversible. And when we do the sleeve to people, there's a higher risk of having heartburn or reflux, because if you remember Laplace's law in physics, when you decrease the radius of something, you increase the pressure in that tube by 4-fold. So that's exactly what happens when we take the compliant stomach and change it into a narrow sleeve of stomach. Next slide. The biliopancreatic diversion is basically a surgery where we bypass almost half of the intestine. We make a gastric sleeve, we spare the pylorus, and then we count about 250 centimeters from the ileocecal valve proximally. That's called the alimentary limb. That is essentially where food goes from your stomach down that limb. The rest of the intestine is basically bypassed. We call that the biliopancreatic limb. And that is basically plugged back into the intestine, into the alimentary limb, about 100 centimeters from the ileocecal valve. So a tremendous amount of intestine is bypassed, and there's only 100 centimeters of absorptive surface. With this, patients get a lot more malabsorption, but they also have a hard time gaining weight back once they lose it. Next slide. So this actually became very successful because of a 70 to 85% excess weight loss. It's even more successful in getting diabetes to go away or have remission. It's also really good at getting rid of hyperlipidemia. Once the the biliopancreatic diversion is undertaken, you almost get near immediate normalization of blood glucose and normalization of insulin sensitivity. So it's ideal in the diabetic patient. Next slide. There are a few drawbacks though, because half the intestine is bypassed. There is some micronutrient and macronutrient malabsorption and malnutrition. So these patients malabsorb their A, D, E, and K vitamins. They malabsorb calcium, they malabsorb iron, B12. So all these things have to be replaced. They have to take actually 3 times the normal vitamins than a regular patient does. Add with that, if they eat improperly, if they eat sugar, or if they eat things that are high in fat, they will get bloating, they will get diarrhea, they will get very malodorous gas. So it helps them stay on track, but if they have tendencies to eat things that they shouldn't be, they're going to have repercussions, which will keep them kind of honest, but it also keeps their weight down when they make bad decisions. Next slide. The SADI, or the single anastomosis duodenal ileal bypass, is just like almost the duodenal switch. The only difference is there's one anastomosis. Essentially, the biliopancreatic limb leads into that single anastomosis, and then the alimentary limb is it's longer, it's about 200 to 300 centimeters. Next slide. The nice thing about this is it takes a 3-hour surgery and makes it about an hour to an hour and a half surgery. And it was basically designed to decrease the side effects of the biliopancreatic diversion because you have a longer common channel where absorption can occur. The mean excess weight loss at 1 year is about 78%, but they still have really good remission of diabetes. They still have really good remission of dyslipidemia, but then also sleep apnea goes away, hypertension goes away, which we see commonly in any of the weight loss surgeries that we do. And studies have shown that there's no difference in vitamin deficiency between the SADI and the BPD-DS at like 2 years, but they do have less severe diarrhea and less severe malnutrition. So the SADI surgery is actually a very common surgery that we're doing now as a revision surgery for people that start regaining weight after a gastric sleeve. So the gastric bypass is a surgery that's been around, like I said, since the 1950s. It's still here today. When we do a gastric bypass, we basically take the stomach and divide it so that now the stomach is about the size of like a large egg. With that said, the lower part of the stomach is actually where the acid-producing cells are in the stomach. So that is now separated from that new stomach, which we call the stomach pouch. Then we bypass the duodenum and a little bit of the jejunum. We bypass about 75 centimeters of the small intestine, and we bring the intestine up to the stomach pouch so that can empty, and then we plug that back in to where we divided the small intestine. So it essentially creates what we call a roux limb anastomosis. It forms a roux and Y, which is a Y-shaped bypass. Next slide. With that, you get about a 55 to 75% excess weight loss. It is probably the only surgery that we do that really improves reflux and gets rid of reflux. So this is ideal in people that have Barrett's esophagus. If a person has Barrett's esophagus, really this is the only surgery that they're a candidate for because it's the most efficient in getting rid of that acid-producing area from the GE junction. The disadvantages of the gastric bypass is the risk of internal hernias that can happen anywhere from a year to 10, 20 years down the road after people lose weight. And the reason internal hernias occur is as people lose weight, they get sagging on the inside of the mesenteric fat, and that allows small bowel to kind of creep into areas where it's not supposed to and cause an internal hernia. There's also a risk of marginal ulcers. That gastrojejunal anastomosis is not used to receiving a lot of basically things like NSAIDs or caustic materials. So when people smoke, which decreases blood supply to the anastomosis, when people drink alcohol, when people take NSAIDs, that could cause an ulcer in that area that's very difficult to heal up. So we basically restrict patients from smoking, and after bypass, we restrict them from taking NSAIDs as well. Dumping syndrome can happen with any of the malabsorptive surgeries. If patients take any sugar, if sugar's in the first 3 ingredients, they could have the dumping syndrome, which basically presents itself as diarrhea, diaphoresis, cramps. Sometimes patients feel like they want to pass out. Oftentimes they just have to lay around until the symptoms pass, and sometimes it could take several hours for that to pass. Although gastric bypass has more deficiencies than the gastric sleeve or the gastric bandage, it doesn't have as many deficiencies as the duodenal switch or the SADI procedure. Next slide. So let's talk about resolution of medical problems as people lose weight. So when we look at type 2 diabetes, about 85% of people that are type 2 diabetics are overweight or obese. So we know that if we get rid of the problem of obesity, we could help resolve diabetes. the incidence of type 2 diabetes basically has doubled from 1980 to 2014. And that's actually when more obesity actually started really skyrocketing. And if this trend continues, it's estimated that 1 in 3 Americans will have diabetes by 2050. If you look at the different surgeries that we do, the biliopancreatic diversion really has the best resolution of diabetes, 95%. The gastric bypass is second at 80%. Gastric sleeve is about 80% as well. And the gastric band is effective in resolving diabetes about 50% of the time if people have diabetes less than 5 years. So one of the key things is, ideally, we'd like to see these patients before they start developing comorbidities. But once they have the comorbidities, these surgeries will help resolve them. Next slide. When we look at dyslipidemia, about 60 to 70% of people who are obese have dyslipidemia. And it's also associated with truncal and visceral fat as well. A weight loss of like 4 to 10 kilograms in these patients actually result in a 12% reduction in LDLs and a 27% increase in HDL receptors. So when we look at dyslipidemia and weight loss surgery, really the best surgery to help get rid of it is the biliopancreatic diversion at over 95% resolution. The SADI helps in about 70–80%, gastric bypass in over 75%. Gastric sleeve is a little bit less because there's no malabsorption, 43%. And gastric band is the least effective out of all the surgeries at 25%. Next slide. Hypertension is also something that's directly related to being overweight, especially central obesity. About 60 to 70% of hypertension occurs in patients that have this central obesity. There was a recent article in the February issue of SWORD of this year that looked at 7,000 patients. And they basically compared sleeve gastrectomy, which is now like the popular surgery, to gastric bypass to see how well it actually got rid of hypertension. And what it found was between sleeve gastrectomy and gastric bypass, the remission rate was pretty much the same, 83% remission of hypertension. And if patients start regaining their weight back, there's actually a recurrence rate of about 12.7%. The gastric band was effective in resolution of hypertension, about 43%, but BPD-DS also had really good resolution of hypertension at 84%. And this study also showed that bariatric surgery leads to about a 50% reduction in heart attack and stroke in overweight patients. So next slide. So NASH, or non-alcoholic steatohepatitis, is now the #2 reason for people to actually get a liver transplant. And 80% resolution of NASH occurs after weight loss surgery. And it doesn't take much. It's basically 7 to 10% of their weight is what's necessary for regression of NASH. So we actually see a lot of patients who have problems with NASH that are undergoing weight loss surgery for resolution. Next slide. Sleep apnea is actually very, very common in patients with a BMI greater than 40. And in studies, the incidence runs anywhere from 40% to 90%. A 10% change in body weight is associated with a parallel change of 30% in the apnea-hypopnea index. And if you look at these different surgeries, gastric band is pretty efficient in helping resolve sleep apnea at 68%. Gastric bypass and gastric sleeve are over 80% in resolution, and biliopancreatic diversion helps resolve sleep apnea in over 90%. Next slide. And then pseudotumor cerebri is one of those things that you don't hear about very often, but if you listen to patients, especially women, you hear a lot of the pseudotumor cerebri symptoms. the risk is 20 times higher in obese women who are under 44 years of age. And in about 80% of children with secondary pseudotumor cerebri, you find that they're overweight or obese. The common symptoms of pseudotumor cerebri include headache, visual disturbances, pulsatile tinnitus, papilledema, and a recent article in the Canadian Journal of Surgery showed how bariatric surgery actually improves symptoms of pseudotumor cerebri. And in fact, it's actually now in one of the algorithms to help get rid of pseudotumor cerebri before shunting. But the symptoms of headache that were like 100% of the time in these patients pre-op went down to 10% post-op. The visual complaints and visual disturbances went from 62% down to 44% after weight loss surgery. Tinnitus went from 56% down to 3%, and papilledema went down from 62% to 8%. And when they did lumbar punctures on these patients, they found that the opening pressures went down from 34 millimeters of mercury down to 14 millimeters of mercury. So it was quite significant. Next slide. I do want to actually, before we talk about the complications, I also want to mention that migraine headaches, which actually happens quite commonly in overweight patients. There's a study that was just done in neurology that showed about a 50% reduction in symptoms of migraine headaches after weight loss surgery and weight loss. So that's pretty significant too. Now, as far as complications of weight loss surgery, probably the most common complication that can happen as people lose weight is gallstones, cholelithiasis and cholecystitis. And that can occur in about 30% of patients as they lose weight, whether it's medical weight loss or surgical weight loss. Because of this, when we operate on patients, we basically put them on medications to dissolve gallstones, and they stay on that during the first 6 months after surgery when they're really losing weight the fastest. When patients undergo something like the biliopancreatic diversion or the SADI, which will not lend us access to their common doctor after surgery, then these patients actually will get their gallbladder out at the time of surgery to prevent potential complications. Leaks can occur in any surgery that has an anastomosis or a staple line, and leaks occur at a rate of less than 1%. And basically, when patients have a leak, we look for things like pain, tachycardia, nausea and vomiting right after surgery. That's kind of like not expected. And if this happens, we do a CAT scan on them to rule out a leak. And nowadays, CAT scans are so good at determining leaks. And the treatment for leaks is basically making the patient NPO, putting them on antibiotics and putting them on TPN for about 2 weeks until that leak seals up. A missed leak could be devastating. It could lead to death. It could lead to serious morbidities. Because we're operating on patients that are overweight, and overweight patients have a lower antithrombin 3 level, these patients are at higher risk for DVTs and PEs. They also don't move around so well sometimes. And so we essentially, any patient that has surgery, put them on Lovenox 2 hours before surgery. We put them on Lovenox while they're in the hospital. And those that have pretty significant venous stasis changes, or that walk with a walker, or have limited mobility, or have a BMI greater than 50, we basically put them on a month of Lovenox post-op to prevent the risk of DVT and PEs. Bleeding rate can happen because of we are giving the Lovenox right before surgery, but the bleeding risk is also less than 1%. Nausea and vomiting is actually pretty common after bariatric surgery, and it's usually self-limited. Very rarely, less than 1% of the time, is it prolonged. The most common cause of nausea and vomiting early on is just the patients have to relearn how to eat and drink because they have such small stomachs now that they're not used to it. Chronic nausea and vomiting, we always look at what is the patient eating. I had a patient that kept coming back to the hospital for readmissions because of nausea and vomiting. And one day I walked into her room and she's eating a full bagel piled with cream cheese and strawberry jelly, and she had a bypass. And I said, no wonder you're having nausea and vomiting. And as soon as we corrected her diet, she was able to overcome this problem of her chronic nausea and vomiting. So key to eliciting nausea and vomiting and the causes of it is looking at the patient's history. If it's early on after surgery, worry a little bit more about things like thiamine deficiency, or is there a stricture in the surgery that we did? Mesenteric vein or portal vein thrombosis is rare, but it can occur. And sometimes the symptoms are vague, just belly pain, a little bit of nausea and vomiting. And so the best way to figure it out is if a patient is not really following the post-op course, they should be feeling pretty good after 2 to 3 days after surgery. Their nausea and vomiting should resolve after about a week or so. If that's a prolonged thing, we will CAT scan them to rule out things like leak, to rule out things like mesenteric vein or portal vein thrombosis. And then there's also the risk of death. Mortality in our hands has been less than 0.1%, but it's something that can happen. The most common cause of death usually is PE. Long-term complications of bariatric surgery include vitamin deficiency and protein deficiency. And so because of that, we basically, at 6 months, we recheck their vitamin and protein levels. At 1 year after surgery, we check it again. And then we check it every year thereafter to make sure that they're not having any issues. Erosion and slippage of the gastric band is something that can happen, usually 2-3 years down the road. So key thing, I'll repeat it, stop any NSAIDs on patients that have gastric band that don't need to be on NSAIDs. And then always a reminder, if they're having vomiting more than twice a week, they need to come see us so that we can loosen the band so that they don't have chronic nausea and vomiting that can cause that band to slip. Internal hernias are something that can happen in the gastric bypass patient, and it happens about 2% of the time. And the classic symptoms of an internal hernia is left-sided upper abdominal pain that radiates to their back or to their left shoulder. And it's usually a crampy type pain. And usually that's the classic internal hernia symptoms. When you suspect it, you get a CAT scan and you can diagnose it. Sometimes CAT scans can miss internal hernias. So just sometimes based on the symptoms, we will take patients to surgery just to do laparoscopy and make sure they don't have an internal hernia. Because internal hernia sometimes can lead to small intestinal compromise, and we don't want it to get that far. And then marginal ulcers are what occurs with gastric bypass when they take NSAIDs, when they smoke, when they drink a lot of alcohol. So we counsel against that from happening. The classic symptoms of a marginal ulcer usually are epigastric pain, burning sensation when they eat or drink, and sometimes it could cause a stricture, so they have chronic nausea and vomiting from that as well. The treatment for that is basically putting them on a PPI and waiting for it to close up. Next slide. So revision surgeries are something that we're seeing more often. Literature shows revision surgeries are happening now up to like 15-25% of the time after initial weight loss surgery. And the goals for revision are really to improve weight loss or improve their restriction or increase their malabsorption to aid their weight loss, improve their comorbidities. And for patients that have the gastric sleeve, it's to improve their symptoms of reflux that could sometimes get bad. The different revision surgeries that we do, I have listed here, and I'm not going to go into great detail about this, other than to say, before we consider a revision, we basically look at a number of things. We look at what is their BMI. how did they gain their weight back? How hard did they try to lose it? And we usually work with them to get them to lose their weight, get their diet corrected before they actually undertake a revision. And then once they undertake the revision, it's basically back to the starting line. Seeing the dietitian for several months, seeing the psychologist all over again, getting medical clearance with the cardiologist, pulmonologist, seeing their bariatric surgeon routinely to make sure that they're on track and they've started correcting some of their bad habits before they consider a revision. Next slide. I will say the dangers of revision is that they actually have a 10 times higher risk of complication like bleeding, leaks, that kind of thing. So it's important to keep that in mind when we think about revisions and you know, who's a candidate for a revision. When we do a standard workup on a patient for bariatric surgery, depending on their insurance, they will see a dietitian for anywhere from 3 to 6 months. And then sometimes longer. Sometimes patients will be seeing the dietitian for a year if they have a poor understanding of what it takes to have weight loss surgery and how to eat afterwards. Everyone undergoes a psychological evaluation. Everyone undergoes an upper endoscopy. And then everyone also undergoes a cardiac workup. A home sleep study or a pulmonary workup basically is dependent on their history. Everyone sees their primary care doctor to get clearance as well. And then we do a panel of labs. And number one, hemoglobin has to be over 10 before they have weight loss surgery. Their hemoglobin A1C has to be below 8 before they have weight loss surgery, and their TSH has to be normal, because patients will not lose weight if they're hypothyroid after they have weight loss surgery. And then if needed, they see either hematology, neurology, endocrinology, depending on their history and medical problems. Next slide. I have you back that up one. Yep. So we've been doing surgeries since 2001, actually. And our group has probably done over 10,000 surgeries altogether. Our St. Francis experience started in 2005. I have to say that we were the first center of excellence in the state of Delaware in 2007. We've been doing a lot of surgeries since then. We're still a center of excellence. We've done about 2,466 total surgeries. You could see the majority of those have been sleeve, bypass, and bands, but the bands have pretty much fallen off since 2010 and being replaced by the gastric sleeve. We've done a few open gastric bypasses. We haven't had to do very many, but now what we're also doing to help our revision patients is offering them the biliopancreatic diversion as well as the SADI surgery. And these two surgeries are surgeries that usually are not offered. They're not offered anywhere else in Delaware and not offered anywhere in our region. The overstitch is a procedure that's done endoscopically, where endoscopically suturing either the sleeve to make it tighter or the gastroesophageal anastomosis of the gastric bypass tighter so that patients will lose weight again. So it's a revisional surgery or a revisional procedure. Because it's not covered by insurance, not too many people are undertaking this procedure. But I will let you know it's about $2,000, and so it actually may be worth it versus having another operation as a revision. Next slide. So as far as complication rates, our complication rates have been very low. Our sleeve rate of leaks over the years have been less than 0.5%, bleeding rate less than 0.8%. Readmission rate less than 2%, reoperation rate less than 1%, and death is less than 0.1% mortality rate. With bypasses, we have leak rate less than 0.2%, bleed rates less than 0.2%, readmission rate of about 0.7%, reoperation rate 0.6%, and death is less than 0.1%. And I'm hoping this year I'm doing a study on our complication risk after revisions. And so I should have that data for you by next year. Next slide. So what things do we worry about when we're evaluating the bariatric surgery patient? Well, number one is abdominal pain. If they have lower abdominal pain, most likely not bariatric surgery related. But if it's upper abdominal pain, especially on the left side, most likely it's bariatric surgery related. So key things to ask is what type of surgery did they have? Usually long-term after a gastric sleeve, we don't expect a lot of complications. Early on, we suspect things like leaks or mesenteric vein thrombosis in the first month after surgery. After that first month, it's rare that they have a complication. But any of the other surgeries, we worry about anything that's left-sided abdominal pain in the upper abdomen. Look at the quality of the pain. Is it sharp? Is it burning pain? Burning goes more with marginal ulcers. Crampy abdominal pain goes more with an internal hernia. And then also look at their associated symptoms that may give you clues to the differential diagnosis. And I have the most common differential diagnoses here, which is leak, cholecystitis, marginal ulcer, internal hernia, bowel obstruction, rarely pancreatitis, or mesenteric or portal vein thrombosis. And these are the things that you want to keep in the back of your mind when you're assessing the bariatric patient. Next slide. The other thing that worry about is GERD. And the most common surgeries that cause GERD is the gastric sleeve. So what type of surgery did they have? A bypass rarely causes GERD. However, if a bypass patient starts experiencing reflux, look to see if they're gaining weight. If they're gaining weight, then most likely the reason that they have acid reflux or the feeling of acid reflux is not because they're producing acid, but most likely because they're eating too much and things are backing up into their esophagus. So history is very important in these patients. Intractable vomiting. If this is happening later on after weight loss surgery, that's an issue. So look at what type of surgery did they have. Did they have the gastric bypass? Well, they might have an ulcer that's causing an anastomotic stricture and making them vomit. Are they developing a thiamine deficiency? If they do, check the thiamine, and it's easily replaced. And so that can help resolve those issues before they start having neurological symptoms. Check their eating habits. That's probably the most important thing, is when a patient complains of vomiting, I go through detailed history of what is it that they're eating on a daily basis so that I know what could possibly cause vomiting. Sometimes gastric bypass or duodenal switch patients could have nausea and vomiting just from eating sugar. So it's important to elicit that history. When is it important to actually refer patients that have had bariatric surgery back to the surgeon? Well, I think any of those problems, abdominal pain, reflux, vomiting, any of those issues, send them back. We would be happy to see them and figure out what's going on with them. Next slide. So I just want to conclude. We know that bariatric surgery is safe, and it's also a very effective method of losing weight. It's an effective tool to help combat disease, but the bariatric patient really needs lifelong follow-up. Once we see them and do surgery on them, we want to see them for the rest of their lives to make sure that they're not having any issues and to make sure that they are compliant and keeping their weight off. Identifying potential problems and early referral are basically the keys to taking care of the bariatric patient. At this point, I will take any questions, if anyone has any questions.
Dr. Wynn, I do have a question that came through. They texted me.
Okay.
It said, I have a patient that has regained the weight after bariatric surgery. What do you recommend?
So, number one, send them back to us. But number two, when you look at all the different diets out there, really the key is staying off the carbohydrates. That's the key to losing weight and keeping it off. The most common cause of weight regain after bariatric surgery is patients are eating like chips, crackers, pretzels that go down really easy, or they've started eating things that have a lot of sugar, or they started drinking things that have a lot of calories. So those are the first three things: is look at what their diet consists of and see what they're eating. And if they're doing any of those three things, have them stop, focus on a lot of vegetables, more wholesome diet, protein, and, limited fruit. And that usually gets them to start to lose weight again. Usually patients are kind of impatient. They don't want to lose weight slow. They want to lose it quicker. And so some of the things that we do is we start them on things like phentermine to try to get them to lose weight again as they're trying to correct their diet, kind of as a tool. If all else fails, then we have them essentially come back and consider revision, or we send them to the dietitian to kind of work a little bit more closely to get their dietary habits changed.
Okay. I also have another question. Do you perform bariatric surgeries on people who are 65 and older? Is that recommended?
Yes, we do, actually. And actually, probably the oldest person that we did was 75. And this woman basically insisted that, what, I'm 75 and I hope to live 15 more years. Please do bariatric surgery on me. And she did great, and she's doing well now. So yeah, there's no upper age limit as long as patients are in good enough health to undergo general anesthesia. And patients are living longer and longer. So we do not want to deny them an operation that can have them have a better life and in their last, 10, 15, 20 years of life.
Okay. And then another question was why, well, I got a text, interesting. Why does tinnitus drop so drastically from the operation or the procedure?
So basically the reason why these neurological symptoms drop is because when you drop the intra-abdominal pressure, basically what happens is there's less pressure on the spine, less pressure on the spinal fluid, which is less pressure in the brain. And that's how these, problems resolve, especially the neurological problems, the migraine headaches, and the pseudotumor cerebri.
Okay, and that's all the questions that I had come through. I want to open it up again. Does anybody have any questions or any thoughts or ideas or interesting facts that they found out throughout the presentation? And I'll give you like about 30 seconds to like raise your hand or take yourself off mute. Okay. All right. I'll take that as there are no more questions. Dr. Wynn, I want to thank you so much for the presentation. I want to thank everybody for being patient with me on this new platform. I promise next time it'll go much smoother. And everybody have a wonderful weekend, and actually have a wonderful Labor Day weekend, which is coming up in a few weeks.
Thank you so much.
All right. Thank you.
Thank you.
Oh, not a problem.
Thank you.